Yeah, live.
Yeah, thank you, Sunil. Very good evening, everyone. And this is, in a way, we can say this is the season 2 of Kaksha. The Kaksha was a good series which was started by Dr. Vishal, so we wish to continue the same. So today we have Dr. Swati as our faculty. She'll be talking about disc edemas, and disc edemas are things which we all see normally in our daily routine practice. So they can come in various forms. They can be sometimes innocuous, secondary, or sometimes they can be harboring a life-threatening disorder. So we need to differentiate them between what is happening and what should be done for the patient. So the idea of Kaksha is we have one didactic lecture by the faculty, and then there are two residents. We have Dr. Divya and Dr. Megha from RNT Medical College, Udaipur, and they are third year residents. They will be on the hot seat. The hot seat doesn't mean that they are the only ones who can ask questions, but anybody in the panel can raise their hand and ask question to the faculty. And the faculty is also can ask questions to the residents on the hot seat. And in the end, we will have a quiz. And the first two people who will type on the chat box will be given the prize for the quiz. So should we go ahead? Let us start. Dr. Swati, over to you.
Yeah, thank you, Dr. Ankur, for inviting me for this Kaksha series. I believe it was one of the popular series for residents, and I continue to that it remains popular only.
You can share the screen and
Yeah.
yeah.
So it's clear now.
Yes, we can see.
Yes, ma'am.
Absolutely fine.
Yeah. So, as this series is basically meant for residents, I have tried to keep my talk in such a way that it will help resident to understand how to go about whenever they face a case of disc edema. What kind of questions you may be asked in your theory exam as well as practical exam, because most of the time disc edema is generally kept as spotters or as short cases. So, considering that, the idea is to have a detailed evaluation of disc edema. So, if you look at this disc, all disc over here, you can see that they all have blurred margins, right? They all have this cupless disc over here. This is the only disc which has a disc pallor, but rest of them you can see has blurred margin, has poor, almost nil cup. So the most important thing here, this is often confused as disc edema. So if I ask you guys which of this you think is actually truly a disc edema, anybody can answer it, whosoever wants to.
And fourth image.
Fourth, right?
Yeah, this is
Severe
the
disc edema.
yeah. So if you look at this looks like a normal disc. This looks like a hypoplastic disc. This one is a pseudodisc edema, even though the margins are blurred, and so is this one. So the most important thing is to understand how to examine a disc and how to differentiate a true disc edema from a pseudodisc edema. So if you go systematically over there, you can understand for swollen disc or for edemas, just having blurred margin is not enough. You should be able to see the elevated disc stereoscopically. So, a 90D examination on slit lamp biomicroscopy is an ideal way to examine the disc edema. Many a times, if you do it through your direct ophthalmoscopy, you may not get that stereoscopic view, and you may falsely feel that because margins are blurred, it's a disc edema, right? So the true elevation of disc is important. Then you have other features like obscuration of peripapillary vessels, which is one of the important sign of disc edema. Then venous engorgement, another important sign of disc edema. And never overlook the presence of other features like exudates and hemorrhage, and also the presence of venous pulsation. So if venous pulsation is present, that means that there is no disc edema. So it is present normally in 20% of population, but it may still be present its absence does not always mean that there is a disc edema, right? So this is how you need to examine the disc. You not only have to examine the disc, but you also have to examine the surrounding vasculature. So any kind of abnormal branching, as you can see in this particular case, you can see that the veins appear very tortuous. The entire vessels appear tortuous. So again, I want to emphasize that just the blurring of margin or tortuosity of vessels does not mean that there is true disc edema. Here you can see that the veins and the arteries both are tortuous, but you can see that the disc is very well, the margins are very well maintained, the cup you can see, and there are no other associated features. However, in other cases, you can see that there is severe tortuosity of vein, you can see blurring, and you can see venous congestion. In this particular case, you can see optociliary shunt. So these are all signs of disc edema or, resolved disc edema. Now, in this particular case, the last figure over here, you can see that there's a gliosis present. So it's an indirect sign at some point of time, this patient had disc edema, which has now resolved. Sometimes in cases of LHN particularly, you may see peripapillary telangiectatic vessels without a true disc edema. So that is also a case where you need to differentiate it from other causes of disc edema. Then, as I emphasized earlier also, just having the blood disc margin is not enough. You may have splinter hemorrhages, you may have exudates, macular star, which is often seen in neuroretinitis. Then you can have retinal hemorrhages, you can have severe retinal hemorrhages as in cases of CRVOs and other venous occlusions. So you have to look at the periphery also. Just looking at the disc is never enough. And as I said, you can see the pattern lines. You can see this, choroidal folds here in this diagram. In this picture also, you can see that there is circumpapillary folds, choroidal folds, which are known as pattern lines. And these are signs of disc edemas. Sometimes resolved disc edemas also, in resolved disc edema cases also, it can be seen. You may have watermarks also once the disc edema has resolved. And you can typically see a gliotic change over here, which is again the sign of resolved disc edema. And this is a classical picture of secondary optic atrophy. So secondary optic atrophy simply means that the optic atrophy is consecutive to the disc edema. There was a previous disc edema which has now resolved and the nerve has gone into atrophy. So it's important to look at all these signs. They not only confirm the presence of disc edema, they will also help you to differentiate the various etiologies of disc edema. So if you have here such an extensive hemorrhages, you know probably it's a venous occlusion. If you have here this kind of picture, extensive disc edema but minimal hemorrhages all around it and hemorrhages limited to peripapillary area, you know that it is papilledema. If you have a half macular star like in this case, you know that it is neuroretinitis. Here, it's a pale disc edema with a splinter hemorrhage suggestive of ischemic optic neuropathy. So as I'm saying that associated features are equally important and they will guide you towards your differential diagnosis, and for investigations, those need to be done. So if you look at disc edema, the most important thing is to differentiate a true disc edema from a pseudo disc edema. Then to know whether this true disc edema is unilateral or bilateral, right? And I will be covering my lecture along these topic. So first we'll learn to differentiate what is pseudo from true, then we learn to differentiate what are the causes of unilateral and then bilateral disc edemas. So there are multiple causes of pseudodisc edemas and residents often get confused between the pseudo and the true disc edemas. So one of those causes is tilted disc, hypoplastic disc, optic nerve head drusen, and medullated nerve fiber. So as I have spoken about it in this presentation earlier also, just looking at disc is never enough. Look at those associated features and learn to differentiate them clinically. So this is the table to show how a pseudodisc edema can be differentiated from a true disc edema. So a 90D examination on slit lamp biomicroscopy is the most ideal way to examine the disc. If you cannot do it on 90D, the other way is to do it on direct ophthalmoscope where you can focus on the retina, and then using same power you can focus on the disc. If you have to change your power to more hypermetropic side, that means that there is elevation of disc, and that will kind of quantify your amount of disc edema also. It's a way to confirm disc edema. In pseudodisc edema, you generally neither have hyperemia nor pallor, but in true disc edema, you will have hyperemic disc, particularly if it's a papillitis. You may have pallid disc edemas in cases of ischemic optic neuropathy. Then you have dilated capillaries on the disc surface. Now, this is important. Many a times in pseudodisc edemas, particularly if it's associated with drusen's or other kind of disc anomalies, your veins may still be tortuous. So just looking at those large veins is not enough. You have to look at those small capillaries on the disc. So in cases of true disc edemas, those capillaries will also appear to be tortuous. The another important sign is obscuration of vessels, which is seen in true disc edema but not in pseudodisc edema. As I've already shown that there will be presence of pattern lines. So in cases of pseudodisc edemas, you may have another, features of vascular pattern like increased number of normal vessels, or you may see increased tortuosity. So just don't focus on that increased tortuosity of larger vessels. Focus on those peripapillary vessels, which will give you an idea whether this is true disc edema or pseudodisc edema or not. And the another important thing that you need to examine is surrounding retina. So in cases of true disc edema, even the surrounding retina will show you the sign of edema, which will not be the case in pseudodisc edema. So the most common cause for pseudodisc edema is dysdrusen. As in this case, you can see that margins very well look very blurred. And if you look at a first look, it will appear that there is a disc edema. But if you look carefully, you can delineate the vessels very well. The small vessels, peripapillary vessels are also well seen. There's no obscuration over there, and the surrounding retina looks absolutely healthy. So clinically, this is how you can differentiate a pseudo from true disc edema or a dysdrusen. Apart from that, you can also do the optic nerve function test whenever you are in doubt and you feel that there is suspicion that this disc may have true disc edema as well. In those cases, you can do optic nerve function test. You can do color vision and contrast vision, which will be absolutely normal in a case of pseudodisc edemas. Right? Now, this picture is a picture where you can see the autofluorescence, right? So this is a very classical or the gold standard for diagnosing dysdrusen. You can see that this fluorescence over here. Is it visible? Can you appreciate it,
Yes.
Dr. Divya?
Yes,
Yeah.
yes.
So these are the dysdrusen. They are seen on autofluorescence, and they are very classical signs. But you have to understand that this will be present only in cases of superficial drusen. If they are buried drusens, you may not be able to appreciate this autofluorescence. Correct? So in those cases, you may have to use other measures. Ultrasound is also one of the way of diagnosing dysdrusen, where you can see 100% spike on A scan, and you can see this hyperlucency here, hypersonic image over here, which is suggestive of dysdrusen with 100% spike. So this is also one of the way to diagnose dysdrusen. And then now most commonly nowadays we have started using enhanced depth OCT, which gives us the image up to the for the buried dysdrusen. So superficial dysdrusens, they are very easy to diagnose. But it's the buried dysdrusen which is often missed on clinical examination, and the disc appears elevated, which often gives the idea of true disc edema. So if you look at the OCT picture over here, you can see that there is this hypoechoic area. I hope you can appreciate this on both the images with the surrounding hyperintense area over here. So this is a very classical sign of drusen, the hypointense area surrounded by the hyperintense area, and it will always be present near the junction, RP junctions along with the retina. Right, this is one of the sign. The another sign could be the deviation of the RPE membrane along with the retinal membrane inwards. So if there's a true disc edema, it will be deviated towards vitreous cavity. However, in cases of pseudo disc edema, the architecture will be maintained and it will be straight and not deviated towards vitreous cavity. Drusen's may also have, various kind of visual field effects. Infranasal field effect is one of the most common field effect, and generally they are innocuous. They do not cause any complication, but sometimes they may cause complication leading to impaired axonal transport and causing direct compression of the optic nerve axons, leading as well as vessels, leading to ischemic optic neuropathy. So one of the rare complications of Drusen is ischemic optic neuropathy, non-arthritic type, but most of the time they are innocuous in nature. You can have other vascular anomalies associated with this Drusen, and these are the, as I listed, these are the complications of Drusen. I'm not going to get into detail of it. So coming to now true disc edemas, you can, whenever a case of disc edema comes to you, it's important to understand whether it's a unilateral disc edema or a bilateral disc edema, because that will give you a rough idea of how to, differentiate, how to make DDs and how to proceed with the investigation. So the most common cause of disc edema, unilateral disc edemas, is papillitis and ischemic optic neuropathies. So generally, the classical teaching in younger patients, papillitis is more common, say below 40 years of age, and in older patients, it is ischemic optic neuropathies, which is much more common. I will be dealing with individual entity one by one in my subsequent slide. So you can have the unilateral disease in both eyes leading to bilateral disc edema. So this presentation can be there in both the eyes, so that you may at times confuse it with bilateral disc edemas also. So you have to kind of your history, your investigations, complaint, everything is going to give you a differential to understand how this is not classically a papilledema, but a papillitis or ischemic optic neuropathies which are presenting bilaterally. So papillitis presents as acute, subacute, or very rarely a subclinical loss of vision, where patient will generally complain of unilateral loss of vision. A female patient who is generally young in her 20s and 30s will come with subacute loss of vision. But nowadays, in view of typical or atypical optic neuritis, we do not have this clear-cut differentiation of male and female, because this atypical optic neuritis, particularly MOG, can be seen equally in both male and females, right? And also in an older population for that matter. So what are the clinical features? So clinically, you can differentiate a typical papillitis from an atypical papillitis, or a typical optic neuritis from an atypical optic neuritis. This is just an overview of optic neuritis. I'm not going to get into details of optic neuritis, but how does it help you to understand the etiology of optic neuritis is what I am trying to present over here. So generally in mild to moderate vision loss is seen in typical or MS-related optic neuritis, while you have very severe vision loss in atypical optic neuritis. By that I mean NMO and MOG-related optic neuritis. So a typical optic neuritis, MS-related optic neuritis is usually unilateral, while atypical optic neuritis is bilateral. The disc edema in atypical optic neuritis is mild to moderate and do not have very severe extensive hemorrhage or exudates. While in atypical optic neuritis, you will have disc and retinal hemorrhages associated with severe disc edemas. This will typically resolve on its own with after 2 to 3 weeks, while this generally has a poor prognosis. Then a typical optic neuritis will not relapse after steroid withdrawal, while an atypical, particularly MOG-related optic neuritis will be steroid dependent. Right, so the common causes for atypical optic neuritis are NMOSD disorder. This has very poor prognosis and therefore it becomes very important to identify this etiology. So if you have a female in relatively older age group, then you might suspect NMOSD, where you have bilateral severe vision loss along with moderate disc edemas, and where you have painless disc edemas and the vision loss is continuing to be progressive. So there you have to suspect NMO-SD. In contrast to MOG-associated optic neuritis, which generally has a good prognosis but has a higher rate of recurrence. Both of these disorders will need long-term management. The other causes include chronic relapsing inflammatory optic neuropathies or optic neuropathies associated with systemic diseases or infection. So when you investigate a case of optic neuritis or papillitis for that matter, you need to, apart from best corrected visual acuity, you need to investigate patient for color vision, contrast vision, and field losses. So the classical field pattern defect here is a central or a centrocecal scotoma. There are other DDs of centrocecal scotomas as well, particularly a toxic optic neuropathies. They may have central scotomas. MS-related optic neuritis, as I said, I think I will skip this slide. It's not important here. This slide is important, how to differentiate an MS-related from the other optic neuritis. So here, as I said, the female preponderance is seen in both MS and NMO-related optic neuritis, but in MOG, your male and female distribution is generally equal. MS is unilateral while the other two are bilateral. Papillitis is much more common in atypical, particularly in NMO and MOG-related optic neuritis. Then, if you do MRI, you will see that the retrobulbar involvement and a long segment involvement involving up to 50% of optic nerve length is more common in NMO and MOG. In addition to that, in MOG, you may see the perineural sheath enhancement also along with the optic nerve enhancement. Right? So these are the investigations that are important for optic neuritis. The MRI is nowadays compulsory. You cannot avoid to do it. And then you should know the right protocol of doing MRI. So the MRI has to be a flare MRI. Just writing MRI brain is not enough. You have to do MRI orbits also, which has to be a fat suppressed along with contrast. So all this is important. Right? So whenever you order MRI, you have to make sure that it's flare for brain and it's fat suppressed for orbit so that you can easily delineate the optic nerve and optic nerve sheath. Then you can do other serology investigation, particularly antibodies against equaporin and MOG antibodies to understand whether this is a MOG related or an NMO related optic neuritis or not. CSF analysis may be required to look at the oligoclonal bond, which is seen in cases of multiple sclerosis. If you have to diagnose an optic neuritis, you should know that CMRI is compulsory. And this is just a flow chart. If there is only optic nerve involvement, it could be CIS, and you have to treat the patient, and a 3-monthly follow-up is enough. But if there is other neurological signs or symptoms or brain is involved or spine is involved, then probably you have to think in features of MS. If there is atypical features of optic neuritis, then you have to do serology. If it is positive for serology, then you know you are dealing with equaporin or MOG. If it is negative, then again you can go ahead and do CMRI spine to understand the etiology better and tailor your management accordingly. Then management includes IV pulse steroids, oral steroids, and immunomodulator. Here you have to understand that IV pulse steroids is given in acute phase. In acute phase, you do not give oral steroids alone. So the IV pulse steroids have to be followed by oral steroids. In long-term management, oral steroids have role. So in acute presentation, oral steroids are absolutely contraindicated, and we all know that ONTT has shown that it may in fact lead to recurrence. But in long-term cases now, because of presence of atypical optic neuritis, you may have to maintain the patient on oral steroids for atypical cases. For MS-related optic neuritis, you need not give long-term steroids. Then for long-term management, you may have to give immunomodulators or immunosuppressants depending on the cause of optic neuritis. The next important etiology of disc edema is ischemic optic neuropathy, which can be anterior as well as posterior. So the posterior ischemic optic neuropathy is not going to show you any kind of disc edema. Only thing that you can see once the episode is over is disc pallor.
Dr. Swati, I'll just interrupt you. I think before we move on to the optic neuritis, like what is the current protocol the children should understand about treatment of a typical optic neuritis as an ONTT and the present scenario? I think that
Yeah, so
can
if
be.
yeah, that's a very valid question, in fact, and I am sure they need clarification on it. So when we are dealing with typical optic neuritis, MS-related optic neuritis, we have to understand that oral steroids are absolutely contraindicated. We have to give IV pulse steroids for 3 to 5 doses, followed by 11 doses of oral steroids. So this is what is classically ONTT protocol for typical optic neuritis. Right? I hope I'm very clear on that. But once you have diagnosed it's an atypical optic neuritis, you will have to give steroids for IV steroids for 5 days. Followed by then, depending, you have to consult neurologist depending on the response to steroids, whether the patient has improved or poorly improved. You may have to refer the patient to neurologist for further management, for plasma exchange or for immunosuppression or for further continuation of oral steroids. So that decision has to be taken either by neuro-ophthalmologist or neurologist, that how you can proceed if the response to your IV steroid is poor or partial. Okay, I hope I'm clear on that, Dr. Ankur.
Yeah, that's fine. That's fine. Because that's what thing which we want to clarify to people that, just all disc edemas or just diagnosis of optic neuritis, we just have not have to end on the steroids. We
Yes.
do steroids and then see what is the response. So typical optic neuritis should respond very fast and there should be a very good visual recovery, right? If this is not falling into that typical, and there are obviously there are other characteristics which are discussed already about the kind of involvement of optic nerve, unilaterality, bilaterality, papillitis, then they fall into the atypical part, and then you have to do something in terms of, I think, trying to save the life of the patient or trying to at least avoid other disabilities the patient can have, right?
Yes. Correct.
Okay. Yeah.
Yeah. So the next commonest cause of disc edemas, particularly in elder age group, is ischemic optic neuropathies, as I said. And you have both posterior as well as anterior. Posterior, once the episode will resolve, what you will see is only disc pallor. While in anterior optic neuritis or ischemic optic neuropathies, it's the preceding disc edema which is always there. And generally the disc edema, if particularly it's an arthritic pattern, then it's a pale optic disc swelling. So ischemic optic neuropathy can be arthritic as well as non-arthritic. And it's very, very important to differentiate an arthritic from a non-arthritic, because arthritic is not only the blindness which you can prevent, it's also a systemic disease. And if we do not intervene immediately, the patient may go blind. And also there can be systemic complications of arthritic ischemic optic neuropathy that patient should be that you should be aware of, right? So, non-arthritic ischemic optic neuropathy is generally seen over population of 50 years, and it's associated with risk factors like diabetes, hypertension, or any other coronary artery disease or stroke or any other neurological issues which can cause arteriosclerosis. So, it's basically the failure of autoregulation of blood flow at the optic nerve head which causes ischemia of optic nerve head. So any risk factor that is going to affect the autoregulation, like disease, as I said, disease like diabetes, hypertension, migration, smoking, or CADs, which will cause, deficiency of autoregulation, may cause a non-arthritic ischemic optic neuropathy. Then there are certain disc characteristics also which predispose a patient to non-arthritic ischemic optic neuropathy. And one of the most important characteristic is small disc with a very small cup. So you have a small disc with a small cup, that particular patient is more predisposed to develop non-arthritic ischemic optic neuropathy as compared to patient who has relatively larger disc with larger cupping. It can also be associated with cerebrovascular occlusive disease and coagulopathies. So patient will classically present with sudden immediate pain loss, generally after getting up in morning. And this is a very classical history that I, got up in morning and I realized I couldn't see. Visual acuity may range from 20/20 to no PL. So patient may just have field defect or patient may have as severe loss as no PL. RAPD, as with any other optic neuropathy, will be present if it is unilateral. Fundus you can see a swollen optic disc, which can be a diffuse disc edema or classically a segmental disc edema. Disc may be pale. It will be more pale if it's an arthritic disease. And very classically, you will have the small splinter hemorrhages, flame-shaped small hemorrhages peripapillary around the disc, which is a sign of ischemia over there. Okay, so this is very classical picture. This particular fundus picture is a very classical of non-arthritic ischemic optic neuropathy. You can see a small disc over here and a cup which is almost as good as absent, small splinter or hemorrhage over here and a pallid disc edema. Here you can see a segmental disc edema inferiorly with the dilated inferior vein. So you can have both the generalized disc edema as well as segmental disc edemas. This disc, you can always look at the fellow eye to look at what was the initial picture of the disc. And you can see here there's a small disc, cupless disc, which is at risk. So these patients are more prone to have non-arthritic ischemic optic neuropathies. And the classical field defect described with this kind of disc edemas are altitudinal field defect. That means that they will respect the horizontal median, right? And often are confused with glaucoma. But if you look at the disc, presence of disc edema, presence of splinter hemorrhage will tell you that this is non-arthritic ischemic optic neuropathy. How do you manage? So there is no such active management or active intervention that you can do. The most important intervention is control of risk factors. So you have to keep systemic conditions under control to prevent the attack in the other eye. The visual prognosis in that affected eye may not be so good that you have to counsel the patient about it, but the idea is to prevent the attack in the other eye, right? The another important cause of disc edema, which is particularly closely related to...
Just stop you, Dr. Swati. Like any role of steroids in ischemic optic neuropathy? Because this is a different kind of disc edema as compared to a disc edema of optic neuritis.
Right. So it has to be very clear that, oral or IV steroids or steroid in any form for that matter do not have any role in ischemic optic neuropathies. They will not improve the final visual prognosis at any cost. So in fact, sometimes if you are giving them, you may actually be worsening the systemic condition like diabetes and hypertension. So you should not start them.
Yeah, thank you. So this is one thing I think we should be clarifying that, when you have a very pallid and very flattish kind of disc edema, maybe you are dealing with a AIUN. And whenever you have a very elevated kind of a disc edema, which is not like a pallid disc edema, maybe it's an optic neuritis. So these are the difference you have, which we can pick up and think about steroids in these cases. Is that message we can give it to the residents that way?
Definitely. If you have hyperemic and relatively more disc edema, then you're dealing with papillitis. And if you have this kind of particularly disc with splinter hemorrhage, so splinter hemorrhage is a very classical sign of ischemia. So if you have those hemorrhages over there, one or two, maybe you are then dealing with ischemic optic neuropathies, and you should completely avoid steroids in such cases.
Yeah, I think we can move forward to the next. Yeah.
Okay. So I was talking about diabetic papillopathy. It is generally seen at younger age with insulin-dependent diabetes, usually bilateral, and does not cause any significant visual loss, and it improves on its own, right? And it needs to be differentiated with non-arthritic ischemic optic neuropathy. Right. What you need to be more careful about is arthritic ischemic optic neuropathy. Why? Because it is generally a systemic condition which is associated with various vasculitis. Particularly giant cell arthritis is the most common association, but that does not mean that the other kind of vasculitis, inflammatory vessels, cannot be blocked and cannot involve this. GCA definitely is the most common cause, and unless proved otherwise, you should always suspect of GCA. Also, you need to understand that the average age group in arthritic ischemic neuropathies, or for that matter, GCA, is relatively higher. So you have GCA somewhere more than 70 or so, while you will have non-arthritic ischemic optic neuropathy in age group from ranging from 50 to 60. So that's one important thing. Then the clinical features are very, very important. You have severe headache, particularly involving the temporal areas of the of your forehead, with low-grade constant fever, with jaw claudication. So if you have these three important clinical features there, it should alarm you that this is probably arthritic ischemic optic neuropathy. On your examination, you will have very severe vision loss, right? And as you can see here, that it's not just the disc which is pale, it's a surrounding retina also which is pale. So all the arteries supplying to this particular part of retina is also pale, suggestive of arthritic ischemic optic neuropathy. In this particular eye, left eye, you have associated central retinal artery occlusion also, which is not rare thing to find. You may have arthritic ischemic optic neuropathy and you may have other retinal arterial occlusion as well present together. On FA picture, you will classically have non-perfusion of choroid, a dark choroid or a delayed perfusion, which helps you in differentiating the non-arthritic from the arthritic one. Correct? But before you can go to a FA, and you definitely do not need FA to it, you have clinical features, as I said, severe headache temporally basically, with jaw claudication, with fever, should alarm you to make a diagnosis of arthritic ischemic optic neuropathy, and you need to understand it's an ocular emergency. So it's important to diagnose it. So the classical way to diagnose it is to do a ESR and CRP, which will be severely raised in arthritic ischemic optic neuropathy, vis-a-vis a non-arthritic one where they will be relatively normal. And you have to give steroids immediately. You can give pulse steroids or you can give oral steroids. You can give any form of steroids, but you have to intervene immediately, because if you don't, then the risk of involvement of other eye is almost as good as 80 to 90%. That needs to be kept in mind. Please do not wait for temporal artery biopsy, even though it is a gold standard, but it can still be negative due to presence of skip lesions. So please go by clinical features. Please go by your investigations of ESR and CRP. If they are raised, please diagnose it as arthritic. Right? You can use other investigations, but they are relatively not so relevant for the diagnosis. As I said, it needs an emergency treatment. The another important thing to remember is that you may have to give maintenance therapy of oral steroids for long time, and you have to monitor the patient based on the ESR and CRP. So you keep on monitoring ESR and CRP, and once it starts coming down, you can taper your steroids, and you have to maintain the patient on oral steroids, say low dose oral steroids around 5 to 10 milligram for at least a year till the ESR and CRP absolutely become normal. It can have other ocular manifestation, but they are not so point of discussion. So this very table or chart is very important to differentiate a non-arthritic from arthritic one. Here the age group is less than 60. Here the age group is generally more than 60. Then you have very minimal to severe vision loss. But in this arthritic one, you will always have severe vision loss, right? So the idea is to prevent the other eye involvement. As I said, 40% of other eye can get involved in non-dendritic, vis-a-vis around 75 to 80% of other eye will get involved in arthritic if you do not intervene. Right? ESR and CRP are important diagnostic criteria and should be done as an emergency. The another important causes of disc edema is Leber's hereditary optic neuropathy. This is generally seen in males in second or third decade, and patient often complains of rapid unilateral vision loss, often followed by the other eye within few days to weeks. Right? So when the patient presents to you, you may find that it's a bilateral disease, but if you take a proper history, you will realize that it was a sequential involvement of other eye within days or weeks to suggest that it's an LHON. In acute phases, you may find circumpapillary telangiectasia, but it's not always present. But if it's present, it's diagnostic. Right? The most common field defect is centrocecal scotomas in LHON. So after unilateral causes, we have here bilateral causes, papillary edema, hypertensive retinopathy, or any of these disease presenting as bilateral disease. So this was a classical case. You can see here a 40-year-old patient presented with vision loss and has a vision of 660, 5/60. Both eyes pupilla relatively reacting. If you look at the picture, you can see that there is a true disc edema. You have small splinter hemorrhages over here. You can see this star-shaped exudates arranged over here at the macula. So it's a bilateral disc edema with bilateral macular star. But what you cannot miss is an extensive edema all around the disc in both the eyes. You cannot miss is this soft exudates here, right? So maybe you can go ahead and give me a differential. Any of you who wants to try?
Divya and Megha, do you think there's some systemic disease which we
Ma'am,
can?
hypertensive retinopathy.
Yes, so it is a case of grade 4 hypertensive retinopathy. If you look at the vessels over here, you can see that they are very arterial constriction over here. There are AV changes present. So what I'm trying to emphasize is just looking at disc edema is never going to give you diagnosis. You have to look at the entire fundus picture up till periphery to make a complete diagnosis. Right? So this is another patient, fundus picture of another patient. You can see how extensive the disc edema. So if it's an optic neuropathy, you will never have this kind of extensive disc edemas, right? Whether it's papillitis or ischemic optic neuropathies or LHONs or neuroretinitis, you will not have this kind of extensive disc edemas and extensive all surrounding hemorrhages. These hemorrhages will extend to periphery also.
There's a
Okay.
one question, Dr. Swati, that how do you differentiate neuroretinitis from hypertensive retinopathy?
Yeah,
I
that
think
I
that's
have in subsequent slide.
okay.
I'll go to it. But as I said, here also it's important that look at the periphery and you can see choroidal infarcts over here. So that's how you need to differentiate. You need to differentiate it on the basis of clinical examination. Also, you can do definitely, you can check the BP of the patient to know whether it's high or not to differentiate it from neuroretinitis. Okay. So as I said, neuroretinitis is rarely affect both the eyes simultaneously and there will be no surrounding retinal changes. All you generally will see a mild disc edema with a macular star in one eye. And you can see here particularly the entire retina is healthy vis-a-vis the previous picture where you had extensive disc edemas. In this case also you had extensive disc edemas, you had splinter hemorrhages, you have choroidal signs over here, you have exudates. So all these are signs of hypertensive retinopathy as compared to neuroretinitis where you have relatively normal retina except for this macular star. Okay, so that's how you have to differentiate hypertensive retinopathy from neuroretinitis, and of course measuring BP will definitely help. The next commonest condition of bilateral disc edema is papilledema. We have to understand the term papilledema is reserved to the disc edemas which is due to raised intracranial pressure. So don't use it loosely for any kind of disc edema. So unilateral papilledema Don't use it like that. So any kind of disc edema are not papilledema. So papilledema, bilateral disc edemas due to raised ICT are classically termed as papilledema. Okay. Most often they can present with false localizing sign because of the compression of abducens nerve against the petrous ligament, giving you a picture of sixth nerve palsy. So if you have a case of sixth nerve palsy, please look at the fundus for disc edemas. That will tell you that whether the ICT is raised or not. Okay. There will be classical history of nausea, vomiting, headache, with or without sixth nerve palsy. But you have to understand that the visual function will be normal till it becomes a chronic stage. Then pupil reaction is also normal until it comes to the chronic stage, and fundus picture will depend on the stage of the papilledema. Okay, what you have to understand is the most important cause of papilledema, and you need to do MRI. The moment you see bilateral disc edemas, which are papilledemas, please get MRI done to diagnose an intracranial space occupying lesion. The patient may be harboring a big tumor over here, which he is not aware of. He may be harboring infection, meningitis, encephalitis, or any kind of hemorrhage, trauma. So all this needs to be ruled out, and it will need neuroimaging. So neuroimaging is must if you have bilateral disc edemas. So as I said, fundus picture will depend on the stage. You have early stage where you just have obscuration of vessels and few hemorrhages, some tortuosity, absence of spontaneous venous pulsation, right? Then once it is established, the exudates develop, the the edema becomes more extensive, and the tortuosity will also become more extensive. You will have macular stars over here. You can have both hard as well as soft exudates. Once it becomes chronic, the exudates and hemorrhage will resolve, but this is how your disc will look. It will look obliteration of cup. The color will change from pink. It will become more pale. It will look like blood margin over here and will be grayish in color, obliteration of cup, and you will also have nerve fiber layer defects. After chronic, it becomes an atrophic disc edema where every other features is resolved, but you can see that this is a classical secondary optic atrophy where you have gliosis and you have blood margin with capillaris disc. And you can also look at the retina over here. It is not as healthy as it you can see in normal person. So even if your hemorrhages and exudates are resolved, you know that this retina is not a healthy retina, and that should make you suspect about the papilledema. This is the clinical grading. I don't know how relevant it is, but you can always read it from the book. Then the classical field defect will be enlargement of blind spot or peripheral constriction in the early stage. But as the disease will progress, there will be constriction of the field gradually, and ultimately, if we don't intervene, whether medically or surgical, patient may end up with just the tubular field. So that has to kept in mind.
Just add up to Dr. Swati, like this clinical grading of disc edema is important in follow-up of benign intracranial hypertension,
Yes,
because
yes.
this is what the neurologists will ask you to grade the disc edema, whether some people would like to do a CSF tap to reduce the intracranial pressure, or maybe taper their, diamox if they want to. So the clinical grading of this disc edema from 0, 1, 2, 3, 4, 5 is important to remember in the practice point of view. I don't know about the exam part, whether the examiners ask it or not, but yes,
I
the
don't think
neurologists
generally.
sometimes they do ask for the grading of papilledema.
Yes, you should be
Yeah,
aware for your
yeah,
own follow-up and
yes.
understanding. Nowadays, you can use OCT also for follow-up, but clinically, it is what neurologists want to know.
And what should be the investigation of choice if you're suspecting a disc edema, vis-a-vis maybe FFA can help, or uh, maybe there's slight blurring of nasal margins. We're suspecting a disc edema and not very clear. Like in this picture A, can FFA help in these patients?
Yes, yes, definitely FFA can help because FA you can see disc leak, which you will not see in a normal disc or in pseudo disc edemas. So presence of disc leak on FFA is a sign of disc edema.
So that confirms that there is a disc leak, and then there is disc edema. The disc leak should be there probably in the late phases, like I think.
It depends on the severity. Sometimes it may
Yeah,
start early also if it's a
early
severe
also.
disease.
Okay. Yeah.
So I was talking about field effects. So you ultimately, if you don't intervene, patient may be left with only a tubular field or may go blind also. So this table is to differentiate papilledema from papillitis, and it's the common question in exam, both in theory as well as in practical, how to differentiate papilledema from papillitis. So papilledema is usually bilateral, may or may not be asymmetric, but it will always, for all practical purpose, it will always be bilateral. While papillitis is usually unilateral. Most important thing is visual and visual functions, particularly color, contrast, visual acuity, will not be affected in early stages of papilledema. It will be only affected when it comes to later stages, as compared to papillitis, where the symptoms will be much more as compared to amount of ischemia. So patient will complain of severe color vision loss. Patient will complain of vision loss. So as compared to your fundus finding, the symptoms will be much more in papillitis. While in papilledema, the fundus finding will be much more as compared to symptoms. Also, the pupil reaction is very, very important. So if you have RAPD, you know it's an optic neuropathy. But if you do not have RAPD or you have briskly reacting pupils, you know it's papilledema, and it will be affected only in atrophic stages. Then associated features like hemorrhage, exudates are seen in advanced stages. Here you will not have those kind of extensive hemorrhages and exudates. Visual field effect is another way of differentiating papilledema versus papillitis. You have enlargement of blind spots in papilledema, as I've shown you, while in papillitis you will have centro or centrocecal scotoma. The investigation, as I said, MRI is must. You want to rule out any intracranial space occupying lesion or infection or hemorrhage if there is a history of trauma. Lumbar puncture is needed if you want to do IIH, because you want to rule out that there is no other cause for papilledema. So there is no infection, no other features to suggest that there is there is some etiology for raised ICT. Right? This is just to show a case of large ICSOL over here associated with severe papilledema over here. Correct? Then management will depend on the etiology. So if it's a mass lesion, definitely you'll have to refer to neurologist. If it's an infection, neurophysician. Again, a neurosurgical intervention is required in most of the cases. However, it's IH or benign intracranial hypertension, which needs an ophthalmology intervention, and they probably may present to us before they present to neurologist. So in such cases, you have to first you have to do MRI to understand, and you have to refer the patient to neurologist to rule out the any other causes, and then you can start ICT lowering drugs, particularly acetazolamide, which needs to be given in doses of 3 times to 4 times a day, again depending on the amount of disc edema and amount of the pressure of CSF. So it's not just that you have to give just 250 mg of TDS is what is required. You may increase the dose depending on the response, and most of the time just 250 milligram 3 times a day is not enough. Then just 1 or 2 slides about IIH. So IIH is diagnosed only when you have normal CSF with raised ICT. So there are criteria. Your CSF should be normal, your neuroimaging should be normal, there should be no other neurological sign except for six-nerve palsy, so which may be there because it's a false localizing sign. So it's once every investigation that you have done turns out to be normal, only then you can diagnose it as IIH. Another important causes of disc edema, and you should never forget it. This I get very often. If you have this kind of edema, many a times it's diagnosed as papillitis, other times it's diagnosed as papilledema. So please don't forget to examine the periphery. You may have signs of choroiditis there, you may have signs of vasculitis here. So please don't forget that these are also the conditions which are going to present as disc edemas, and just looking at the disc is never enough. So just to, put a conclusion slide over there. your history. First, you need to know whether there is vision loss or not. Then you have to know whether it's a unilateral or a bilateral disease. Then systemic history is equally important. History of diabetes, history of headache, vomiting, temporal headaches, jaw claudications, type of vision loss, sudden, acute, subacute. All this is important. Examination, visual acuity, pupil reaction is very important because presence of RAPD will guarantee you that there is an optic neuropathy. Absence of RAPD should make you suspect whether the optic nerve is involved or not. Fundus examination, as I've showed, that you can have various type of dyskinemas or various other associated features which will give you an idea about the etiology of dyskidema. Confrontation, if done in OPD, will tell you a gross kind of field effect that is present, and it's not very difficult to do. You just have to ask the patient, do your confrontation, and many a times patient will be able to tell you what kind of field effect is that. And if that will also give you an idea that what differential you are dealing with. Investigation, particularly visual functions in form of contrast, color, and visual fields are required to differentiate the etiology. Imaging, depending again on the case, on the etiology, if it's a trauma, CT scan is useful in acute trauma. So that's the only condition where you want to do CT scan, presence, history of acute trauma. In all other cases of optic nerve, optic neuropathies, or dyskinemas, MRI is the investigation of choice. I think I want to emphasize this point again and again. So this is how you want to go about whenever you have a case of dyskidema, right? I hope it it is useful to you. And I think I'll stop my presentation over here. Thank you.
Any questions do we have to Dr. Swati, or any comments anybody would like to have from the audience, the residents, especially Dr. Divya and Dr. Megha?
Ma'am, in a patient with bilateral disc edema at first presentation, can we start acetazolamide, or what treatment we can give? Or we have to just send the patient for neuroreference initially?
See, at the first presentation, that will again depend on number of factors. As I said, history. And if you're suspecting papilledema, the first investigation has to be MRI, even before you start treatment. Right, so MRI has to be done. You can give ICT lowering agent like acetazolamide on your own. You need not consult neurologist, but then you have to be sure that it's a disc edema due to raised ICT. So just don't start acetazolamide because you're seeing a disc edema over there, right?
Also, maybe it can have little bit of effects on the opening pressure of CSF if the
Yes, if
neurologist
it
wants to
does.
do that.
Yeah, if they want to do that.
So until and unless I think you have diplopia, or maybe you are thinking that this is going to be a significant side-threatening or a life-threatening kind of a disorder, maybe uh, because even if it's a papilledema, it's not going to have a sudden vision loss in a couple of days, right?
Right, definitely.
So until unless you have a BIH with the diplopia, you may probably give Diamox to at least elevate the diplopia.
Yes, but I think the first way is to do an MRI to understand what
Yeah,
is.
that's what I'm saying. First is to do an MRI, not to start Diamox.
Yeah, not to
There-
start Diamox.
Yeah,
Yes,
there's a
definitely.
question, can we differentiate between optic atrophy due to optic neuritis or AION?
See, both of them, if optic neuritis, if it is presenting as papillitis, it may be difficult to differentiate from NAI. And once, it has the edema and everything else has resolved. But you can still do it by history. If you have history of atherosclerotic risk factors like diabetes, hypertension, you should be able to differentiate both. And you can also look at the history of pattern of vision loss. You can look at the visual type of visual field effects to understand that what could be the cause of dyskidema in such cases. But if everything else, if the episode has resolved and the vision is poor, then it may be difficult. Because optic neuritis many a times will have good prognosis unless it's an NMO-related optic neuritis.
There's another question like toxic optic neuropathy. A chronic alcoholic is denying PL both eyes. Now, how do we do about it? It's a toxic optic neuropathy. The patient is denying chronic alcoholism, And what do we do about it? That's what is the question in the chat box.
Okay, if you have such a toxicity may not have such a severe vision loss. PL negative kinds, they may have profound vision loss, 1 by 60, 2 by 60. Again, you have to go by um, history. So if there's no history of alcoholism, maybe you have to rule out the history of other drugs, particularly ethambutol and other optic neurotoxic drugs. So please go again, check again if there is any history of ethambutol or not there. That's the most common cause of toxic optic neuropathy in India.
Maybe it could be Leber's also if it's a young male. We may not find anything at all, and this is just the optic neuropathy, which may label it as toxic optic neuropathy, but it was actually hereditary optic neuropathy.
Yeah, that will
That can
depend.
be a confounding factor.
Yeah, that
Yeah.
can be a confounding factor. Sometimes even the livers can get precipitated because of toxicity.
Yeah, smoking and all can
Yes.
precipitate. Yeah. And there's a question about, do we have some fundus findings in ethambutol toxicity?
Generally not. Only in chronic cases you may have dyspallor. In acute cases you may have normal fundus.
Any OCT finding on the ethambutol toxicity?
You can have RNFL defects in very early cases, but more than that, I think it's the symptom of the patient which is going to give you idea. If the patient is complaining of color loss or a central defect, it gives you more often an idea of toxic optic neuropathies.
I think visual field can be one thing which can help us in finding out the ethambutol toxicity, because sometimes you can have bitemporal hemianopia because of ethambutol toxicity,
Yeah, you can.
which can also be picked up in the absence of pituitary lesions. And
Mhm.
OCT findings, I think, are more profound on the macula in the hydroxychloroquine toxicity rather than the ethambutol toxicity.
It is
Yeah,
thinning.
GCL loss will be more
This
common
loss.
with HCQ toxicity, but RNFL loss can be seen in ethambutol toxicities as well.
What is treatment of ethambutol toxicity if we diagnose it early?
So the
To stop it and
first and the ideal treatment is to stop ethambutol,
yeah.
right? And then you can definitely give, a cocktail of multivitamins, particularly B12, B6, and zinc, because it's the zinc and the copper pathway which is a problem in that case. So B12, B6, and zinc probably will help.
There's one more question. Can labbers present with normal fundus and denying PL? Say no PL and normal fundus, can this be labbers?
Absolutely. If the patient is complaining with the sudden vision loss, yes, you may find normal fundus.
But then I
Yeah.
think we'll have to do a battery of
Yes,
investigations to kind of find out whether the patient is malingering or not.
that too definitely. Clinical exam, pupil examination is the most important thing to differentiate an optic nerve disorder from any other cause, for that matter, malingering. If you
Yeah.
have a normal fundus with normal pupil and PL negative, it is definitely malingering.
So another question, there is any role of topical anti-glaucoma drops in disc edema?
No, not at all.
Disc edema can actually precipitate with lower IOP. So
Yeah.
that's not the correct thing to
Mhm.
think about, because if you have more CSF pressure, low IOP, you will have more disc edema. So
Disclaimer.
then there's another question. A patient with RTA turns up and everything is pointing towards traumatic optic neuropathy and cannot be started on IV steroid stat. Does oral steroids play any role? And what is the critical time for same? So basically, this is a RTA with traumatic optic neuropathy, but probably we cannot start IV steroids. So do we give oral steroids, and what is the critical time for oral steroids?
See, traumatic optic neuropathy is one condition which is very difficult to manage because it has very, very poor prognosis. And the most important thing I say here, that if you have cerebral edema, please do not give any form of steroids. It can worsen the patient's general condition, right? Most commonly, what studies have shown, if you give steroids within 48 to 72 hours, they may work. But again, there's a huge controversy. We do not know whether they actually work or not. many of the subsequent studies have shown that it will not work. In fact, it may worsen the situation. So again, I said it's a call that you have to take. If patient is presenting to you, has no other neurological issue, has no cerebral edema, and is presenting to you within 48 hours, you may think of giving IV steroids or oral steroids in higher doses for that matter. But you have to be very, very careful, and you have to explain the patient the poor prognosis. The only thing that determines the prognosis in traumatic optic neuropathy is the baseline vision. If the baseline vision is poor, the final vision will be poor.
So if it's a no PL, we don't expect a significant
No.
improvement in vision. If
No.
there is, say, vision of 660, 636, then we do expect some vision to recover or come back to the patient.
Correct.
So any other questions you have? So I think this summarizes most of the disc edema. So disc edema comes in various colors and various forms, and all disc edemas are not space-occupying lesions in the brain. Not all disc edemas are amenable to steroids. Some of them we have contraindication as a treatment for the to be given in the form of steroids in these disc edemas. So I think with this we will end today's class. Thank you, Dr. Swati, for taking out time, and thank you, everyone. So we had
Thank you.
around,
Thank you, sir.
Thank you, ma'am.
Dr. Ankur, thank you for
ma'am.
having me.
yeah, and think we had more than 60 attendees this time. And there was no quiz. I think we missed on the quiz somehow.
If you want me to ask one question, I can just ask it like that.
Yeah, I think there should be one question, and the person who types fast, first two persons will get the prize for the quiz.
Yeah, I think I'll ask one important question that I think we should know because it's an emergency. How do you differentiate a non-arthritic versus arthritis? If you have to do just one test, what test will you do?
So the question is one test to do between. So there are two people who have answered ESR.
Yes.
ESR, color vision,
CRP,
CRP,
CRP.
CRP.
Only
Sir, type करना है. So what is the correct answer, Dr. Swati?
Yeah, you have to look at ESR, CRP.
ESR, CRP. So there are two people who have wrote ESR. There are four people who have written CRP. So we give it to the people who have written ESR.
Yes.
Okay. So Dr. Arif and Dr. Kunchalata. So thank you everyone for this nice class, and thank you Swati for enlightening everyone with this nice class on disc edema. And will be happy to host many more kakshas with everyone. And thank you everyone who attended the class.
Thank you, Ankur. Thank you, Ankur, for holding such a wonderful academic activity. Compliments to you.
Thank you, sir. Thank you, sir. Nice to see you.
Thank you, sir. Thank you.
Thank you, Dr.